Dr. Emmitt Riley, or Dr. Emmitt Y. Riley III, is an associate professor of political science and Africana Studies at DePauw University in Greencastle, Indiana. He also serves as the rector of the Africana Studies Program. Dr. Riley earned a bachelor's degree in English and political science in 2008 at Mississippi Valley State University. He earned a master's degree in political science from Jackson State University in 2010. And Professor Riley continued his education at the University of Mississippi, where he earned a master's and PhD in political science with a specialization in American politics and international relations in 2014. He is an expert in American politics, Black politics, legislative politics, and racial attitudes. In 2021, he was awarded the G. Bromley Oxnam Award for service, as well as named the DePauw Faculty Member of the Year. There's a whole lot more on Dr. Riley on the event website, as well as his website. But I am just so excited to welcome him and welcome you into this conversation about how the pandemic has magnified the disparities in healthcare. And without further ado, because we did start a little late, I do want to hand it over to Dr. Emmitt Riley. Dr. Riley, it's all yours.
All right, thank you so much for the opportunity, and I'm happy to be here with you today. I am a political scientist, and we usually don't present on healthcare disparities. However, the nation has engaged in some very interesting conversations about healthcare within the last 10 years, how we've defined it, whether or not it is a constitutional right or whether or not it's a personal responsibility. Much of my research deals with racial attitudes. And so in my own work, I have discovered, or shall I say researched, the way in which racial attitudes now predicts Americans' attitudes towards healthcare. And so I have put together a presentation. I also sent an article that I think grounds what I'll talk about today. And because this is a presentation, feel free to stop me and say, Dr. Riley, I have a question or whatever. I would like this to be more conversational than simply me talking. So how has the pandemic magnified disparities in healthcare? There are a couple of things I think we need to start with in order to get an understanding. We know from data that minorities in the US, and when we talk about minorities, we're particularly talking about non-white people. It's important that we also realize that the term minority can be offensive because people of color are not minorities on the globe. When we look at the distribution of populations across the world, people of color actually comprises of a majority of people. Yet in America, different racial groups have been classified as minorities. So when we conceptualize it under that standpoint, we know that minorities typically have high rates of infant mortality, suffer from heart disease, diabetes, and it should reach strokes and so forth. There are issues with respect to access to healthcare. And we also know that minorities are more likely or less likely, to be believed when they have concerns regarding their health. And some of the when we ask this question, why are there disparities in healthcare? We typically point to issues like poverty. We point to issues like unemployment. We point to issues like high school education and health insurance access. And I think that while these explanations show us a connection between these disparities that exist, it doesn't really get at why is it that poverty is being maintained that is also having issues with disparities in healthcare? Why is it that we have such high unemployment rates or high education low education attainment rates? And even why is it do we have sort of these access issues when it comes to healthcare in the nation? Because we know that if we know that a particular group of people are more likely to have heart disease, diabetes, stroke, issues in infant mortality rates. And then we get this very terrible virus that disproportionately affects people of color and people who have pre-existing health conditions, then it's not all that great of a discovery that, wow, the pandemic has magnified healthcare disparities. But when we talk about the way in which it has magnified healthcare disparities, it's important to think about access. You know, we think about if you get COVID and you have heart disease, you're more likely to be sick than someone who doesn't have it. But there are other issues, right? People who disproportionately suffer from many of these ailments also have to go to doctors. And so the pandemic has affected one, our ability to have access to medical professionals because we can't walk into offices like we used to. There are issues with respect to the way doctors are now conducting holding patients, or if someone is sick, being able to be with them at the hospital. So I've shared, I want to define a couple of terms, and some people may say, what does racism have to do with healthcare access? And I contend that everything. One, I think we should define racism. This is the definition taken from Racecraft by Barbara and Karen Fields. And they define this concept, I think, in one of the best definitions I have seen, is that it refers to a theory and the practice of applying a social, civic, and legal double standard based on ancestry and to the ideological surroundings of such a double standard. So when we think about if poverty is related to healthcare disparities, if educational access is related, if we see correlations between education and healthcare disparities, then we should be thinking about what is maintaining these disparities. What is maintained? And I contend that when we have institutional and systemic inequalities that exist, when people live in certain parts of the community where the air isn't clean, the water isn't clean, when you live in areas of high stress, these factors typically will impact a person's ability to have access to health care, and also seeing the magnification of the disparities that exist between racial groups. A couple of things. This chart here details, it's a racial resentment scale. And this is how we typically measure racial attitudes. And it's gonna connect to the healthcare argument in a minute, because people may be saying, okay, what does this have to do with healthcare? The first question reads, generations of slavery and discrimination have created conditions that make it difficult for Blacks to work their way out of the lower class. Simply put, Blacks should try harder. When we deal with most explanations of access to healthcare or any type of entity in the US, we typically don't look at systems. We blame individuals. So we say that if you don't work hard, your plight is because if you don't work hard, it's your own fault, that you should pull yourself up by your bootstraps. The second question says, it's really a matter of some people not trying hard enough. If Blacks would try hard enough, they would be just as well off as whites. Italians, Jews, and other minorities have overcame racial prejudice and worked their way up. Blacks should do the same without any special favors, which measures the undeserved advantages. And the fourth measure is, over the past years, Blacks have gotten less than they deserve. Now, these questions are known as the racial resentment model, which was first put to test in 1981 by Kinder and Sanders. In 1994, they write divided by color. And what they find is that these attitudes predict Americans' policy preferences on political choices, vote choices, public policies, and so forth. But in most recent years, this particular framework now predicts white attitudes and Hispanic attitudes and Asian attitudes as well in America about attitudes. It predicts support for government healthcare. And so scholars have started to uncover whether or not healthcare in America has become a racialized entity. So what do I mean by a racialized entity? The social psychology literature in political science and social psychology suggests that when public policy issues are associated with racial figures, that those issues can be viewed through what's called a racialized lens. That is, if we associate, for example, Barack Obama, this is an article by Tesler and Sears, adopted the water poodle. These are some nice dogs. I actually have a golden doodle that I've fallen in love with. And what happened is Barack Obama's association with the water poodle predicted white attitudes about their approval of the dog. And so another way to look at this is when Jesse Jackson ran for president, in the Democratic Party primary in the 1980s, many whites associated the Democratic Party with Jesse Jackson, and the party became seen through a racialized lens. Scholars today are now suggesting that the American Affordable Health Care Act has become racialized because of its association with Barack Obama. And so if we think about many of the states who've refused to expand the Affordable Health Care Act, one of the problems is these are some of the poorest states in the nation. These are some of the states with some of the worst healthcare outcomes in the nation. And so so much of what the scholarship is suggesting is that support for the Affordable Health Care Act has absolutely nothing to do with whether or not a person supports the healthcare policy. It's tied to a disdain for the author of the bill, in which it was associated with a figure that we see as polarizing. So here are some socio-environmental maps of poverty in the US, and this is from the CDC. And one of the interesting things about this map is that we explain healthcare outcomes that are inherently linked to poverty. So if you are poor, you're more likely to have heart disease. You're more likely to have a number of different ailments that exist in our world. And so it charts it by the percent of people living in poverty. And one of the things we know from the data is that those high impoverished areas also have some of the worst healthcare outcomes. But I would also challenge us to think about this part in the South here, where we see a large percentage of African Americans clustered who also have some of the worst healthcare outcomes. And one of the interesting correlations here is the relationship between these former states of the Confederacy and failure to expand healthcare. Another explanation is unemployment. And so when we see areas with high unemployment rates typically have worse healthcare outcomes as well. And high school education has become another variable that scholars have looked at to explain healthcare disparities. But I want to challenge us to think about, it isn't just poverty or unemployment or a lack of a high school education. What's more important is, what are the systems that maintain poverty that also predicts worse healthcare outcomes that we have in our system in the US as well? Because if we look just simply at poverty, we miss the systemic nature of how healthcare and access to healthcare in this nation actually works. I've also included some other data here where we're looking at the age-adjusted risk of COVID infections, hospitalizations, and death compared to white people in the US. And so one of the things we see here is that when it comes to the number of cases, it doesn't appear to be that much of a difference between Blacks and whites using this particular chart. But we do see inherent differences between Hispanic and Asians. And when we look at hospitalizations, the gray chart here represents the number of whites, and the other blue charts represents Indian Americans, Asians, Hispanics, and Blacks. But what we consistently see from this chart is that minoritized groups in the US, whether it's hospitalization or deaths, are disproportionately impacted by the COVID pandemic, primarily because prior to the pandemic happening or COVID happening, these groups also had higher levels of heart disease, diabetes, stroke, and a number of different ailments. So there is the general expectation that if there is a virus that is likely to impact people who have worse healthcare outcomes already, they're more likely to be affected negatively, both through hospitalizations and deaths as well. This other figure here charts the COVID weekly cases in the United States per 100,000 by race and ethnicity. And the green line represents the white population. The light blue represents Black. You have the orange Hispanics, and then there's a dark blue line that looks at Asian and Pacific Islanders. But one of the conclusions I think that's obvious from this map is that there are profound differences between the way, even when it looks at the number of cases that have happened stretching from April 2020 to January 2022, there's still profound differences between Blacks and whites, Blacks, whites, and Hispanics as well, and even Asian Americans as well, in terms of how the impact of this pandemic on these particular groups. So the question that I think we should be asking is, why has the pandemic impacted minorities disproportionately? And I suggest that it has impacted minorities disproportionately because of systemic inequality that exists, because of systemic racism that has come as a result of years of our inability to fix economic systems, even in areas in the South. I think about my mother, who has cardiomyopathy, and she lives in the Mississippi Delta. In order for her to see her cardiologist, she has to travel 1 hour and 45 minutes. And she's had issues with her heart during the pandemic, which has prevented her from being able to go and see her doctor the way she was doing in a pre-pandemic world. And so when we think about, it's not just the fact that we have these disparities that exist, there's also the issue with access. There's also the issue with whether or not people have insurance. There's also issues with healthcare costs in the US. And when we think about my home state, Mississippi, for example, who failed to expand the Affordable Health Care Act, we ended up having a issue where our hospital became so overwhelmed that they turned a football stadium into a temporary hospital because of the hospitalization rates were so high. And just prior to that, the state refused to expand the Affordable Health Care Act. And in addition to that, they had to lay off medical professionals. And so these are some issues that I think that we know that these disparities exist, but moving beyond that, there are disparities and that Blacks and other minorities have been disproportionately impacted by the pandemic. We've got to fundamentally deal with the causal elements of what is causing this poverty, what is causing these high unemployment rates, what is causing some of these diseases that we see that disproportionately affect Black people in a very high and alarming rate, and what is it we can do about it. And so I've sort of explained the process of racialization of healthcare, which is the process by where racial attitudes are brought to bear on the political preferences rather straightforward for race-targeted policies like affirmative action or federal aid to minorities. For example, we know that issues, so if a policy is explicitly mentions race, there's the general expectation among scholars that the policy will elicit a racial reaction. But when we think about issues like healthcare, we don't really consider healthcare as a racial issue. We generally think that healthcare is an issue. We all have to deal with it. We all need health insurance. We want to exist in a society where people have the best healthcare. I comport that when we begin to think about racialization in healthcare, central to this debate is whether or not we see healthcare access as a constitutional right, or is it something that someone else is responsible for getting? And when we also think about the number of people who file bankruptcy, a lot of people file bankruptcy as a result of extremely high medical bills. And so this was a map from 2014 of the states that refused or were not moving forward with the implementation or expanding the American Affordable Health Care Act. And if you go back to my previous charts here, we see pretty much, if we're looking at the states that haven't refused, these states have some of the highest healthcare outcomes related to poverty, related to unemployment, related to high school education. Now, moving on to the politics of the matter, because I am a political scientist by training, and politics is always at the forefront of what I'm thinking about. We heard debates in Congress about everything that was wrong with the Affordable Health Care Act, how it needed to be, premiums were high and yada, yada, yada. Yet when Republicans took control of the legislative chamber, even under a Republican president and a Republican-controlled Senate and a Republican-controlled House, they were still unable to repeal the Affordable Health Care Act. And the reason they were unable to do that is because politicians realized that, yes, for everything that we thought was wrong with the Affordable Health Care Act, a great deal of white Americans were benefiting from this policy. And that to take this policy from white Americans would likely cause backlash during the election, which is why you did not see Republicans being able to muster the votes in the US Senate to actually repeal and replace the Affordable Health Care Act. Now, all right, so in the article I sent, it's an empirical article that looks at the way in which racial attitudes predict attitudes about healthcare. We know that the Clinton administration in 93, 92, I think he put Hillary in charge of the task force, was designed to bring about this idea of universal health care, which has been a major policy issue for Democrats going back at least into FDR. In this article, essentially, if you go through all the data and read it, what Michael Tesler demonstrates empirically is that there are profound differences at the way in which white Americans evaluated the healthcare policy when proposed by Clinton versus the healthcare policy when it was sponsored by Barack Obama. And chart 4 demonstrates some of the descriptives of whites' responses to this policy, which suggests and supports the argument that this debate about healthcare, at least the healthcare policy component, had very little to do with the policy on its merits and more so to do with who the policy was associated with. In my forthcoming book, we examine the extent to which racial prejudice, white identity, and racial resentment predicts healthcare, predicts white Americans' attitudes about expanding healthcare. And what we find, according to our regression analysis here, is that racial resentment, which was those 4 questions that I included at the front, were significantly more likely to predict white attitudes about healthcare than racial prejudice. So we see, if we're looking at this particular chart, looking at the healthcare coefficient component, we see a statistically significant coefficient at 0.005, which suggests that it is highly statistically significant. I'm not sure why these red things are coming across my screen, but they're there. And that coefficient is significant, which suggests that white Americans' attitudes in this particular model was inherently tied to those 4 questions on racial resentment. We also looked at racial attitudes among Hispanics and Asian Americans, and this is, I think, the Hispanic model. And what we also find is that issues that predict healthcare among Hispanics were also the racial identity. So for Hispanics who saw that their race was more important than their American identity, they were more likely to support policies like healthcare because they saw them as being a benefit to most people. So I'll stop right there for the sake of time, and I'm willing to engage questions. I was told that there were a lot of healthcare professionals who had joined the call, and it would really be interesting to hear from healthcare professionals about the way in which they see these issues playing out with respect to healthcare access, with respect to explaining disparities, because we can talk about the disparities exist all day. And we can go through countless data models of talking about the alarming rates of infant mortality, diabetes, stroke, cancer, heart disease. The question that we must push scholars and healthcare policy professionals to also ask is, what are the systems that are maintaining these disparities? Because we know that they exist. That's like intermediate level knowledge to say, okay, disparities exist. COVID also is going to amplify these particular disparities as well. The question becomes, how do we move towards a society where we are really, really critically interrogating what is maintaining these systems? And it's so many different moving parts. It's simply beyond the disparities. There are issues with access. There are issues with, even when you go to a doctor as a minoritized person and you're explaining what's going on with you, and also feeling like your complaints or issues haven't been heard. There are also, I went home, and I'll share this, Leslie, be sure to pull my coattail if I'm going too long now. But I remember going to the hospital, I was having stomach issues. My father passed away from stage 4 stomach cancer, which is a genetic cancer that seems to run in his bloodline. And I was having gastro issues. I was attempting to explain to the doctor, I know this is an emergency room visit and you probably won't deal with this, but I felt like I wasn't heard as a person saying, this is a concern I have, because when most of my family members discover that they have this disease, it's at stage 4 and they usually don't last a year out. And that went unheard by the medical professionals. And I cannot tell you the countless studies and narratives that demonstrate how minorities go to doctors and they walk away feeling like the doctor hasn't listened. The healthcare professionals haven't heard them out. And so I think that when we begin to think about so when we think about systemic racism, am I saying the doctors are racist? Absolutely not. What I am saying is that we have set up a system that reinforces these racial disparities that exist in healthcare, and we go to these low-hanging fruits like poverty and unemployment and all these other common sense explanations that we know explain or have a significant relationship, but we don't ever say, how do we think about having an environment where the air is clean and the water is clean? How do we improve services for preventative care for people? How do we improve healthcare access to people? And a lot of it is tied to the way in which we think about individual behavior. Because we think about, I've known people to work out and fall out and have a heart attack. I've known people who've been, healthy, who suffer from these different elements. And so I'll be quiet right here to take any questions or engage in sort of a dialogue.
Thank you so much, Dr. Riley. We would love for you to engage with us with your videos on, if you are able to. I know I have tons of questions and I could probably talk about this for hours, but Max, I see that you've unmuted yourself. So Mr. Hittle, if you want to go ahead.
I do have a question. Let me introduce myself. Dr. Riley, my name is Max Hittle. I'm an old guy, graduated in 1966. I'm a political science major, went to law school, really enjoyed constitutional law. Like you, I follow politics fairly regularly. And I want to give you an example of what I'm seeing down here in Florida, which I think falls into your category of systemic racism. And my question at the end of this little diatribe will be, what do we do about this? A year ago in January and February, my wife and I stayed back in Indianapolis for a month and got our COVID shots because it was really accessible, no problem. We didn't get down to Florida till about this time last year. Well, I take the Naples Daily newspaper, which is a lot of fun to read, and I find out that as soon as I get here that the federally mandated COVID vaccines are on their way to Florida. And the Florida Public Health Group was in charge of trying to allocate these to communities, healthcare centers, what have you. And we found out that our Governor DeSantis, was diverting a lot of these first bunches of vaccine up to a couple of very populous retirement places like the Villages, where there are lots and lots of doors of senior citizens, lots of people who probably supported DeSantis. Down here in Naples, in East Naples, where we have a large population of African Americans, Hispanic Americans, a lot of whom work in agriculture, they simply weren't getting these. They would ask their county health commissioner, they'd ask the state to say, hey, wait a minute, we're the ones that are putting food on the tables down here in Southwest Florida. Why aren't we getting these things? And there was no answer. So you don't have to be a sociologist, in my thinking, to figure out this is part of the problem. It doesn't necessarily have to do with education, pre-existing healthcare issues, that sort of thing. It's just out and out political misappropriation of valued assets. So what do we do about that? This is no mystery.
Yeah. So I think Florida is a very interesting state. I've been following Governor DeSantis and a number of his policies that he has been authoring in Florida. I think within the American context, we have this thing called federalism under the 10th Amendment, which says all powers not given to the federal government are reserved to states respectively, which allows states to maintain a high degree of autonomy about how they regulate healthcare within their borders. And when you have a governor who does not believe in science or who does not take the necessary steps to ensure public safety, this is a result of that. And so I think one of the things that we need to do is states have got to be very conscious about who they elect to office, because that determines a lot. It determines a lot about access, about the policies that you're going to have instituted with respect to combating these issues. So that's one thing about what we can do. People need to become more involved and making certain that they're electing people who have the public interest at heart. But what's really, really interesting about what do we do about healthcare access, Tangela Purnell, she actually came to DePauw to speak last year. She's a professor of public health at Johns Hopkins, and she's doing some very, very good work on health equity and health access. And there is a lot of good work out there, but we also need movements in policy. We also need healthcare professionals who are racially conscious, because a lot of times what we don't see in healthcare training is the ability to equip healthcare professionals with how do you deal with diverse communities. This is actually, it's kind of funny, but it's not funny. When I a few years ago, I had a heart attack scare, and I went to a cardiologist, and the cardiologist was like, okay, there's something weird going on with your heart, but what doctor did you go to tell you that? And I said, well, I went to X doctor, I won't call the name. And they said, well, as an African-American man, we see this particular rhythm in African-American men's heart more than others. So I think part of it is also educating healthcare professionals about being racially conscious or being culturally sensitive to different groups. The other element is political engagement, and that involves who we're electing to office, the types of healthcare policies that we're advocating for, and also building coalitions. So that's the short answer.
Let's say I was going to get my master's in public health from some university, you pick it. Is there likely to be a course or a portion of study in my master's in health that would focus on these issues that you've outlined for us? That is the innate things that we have built into our health system that stand in the way of good, effective, equitable delivery of healthcare? I mean, are we looking at this?
Yeah. So my short answer is I don't know, because I'm not I don't teach public health. I would imagine that there are some programs that do offer those courses, because I know Johns Hopkins has got they just got a $54 million grant to do health equity work through the National Science Foundation. And so it would be great as if we could see more healthcare professionals who emerge from their training with training to how do you deal with people who are different from you. But I think that I'm not so sure if that is the norm in health in public health programs.
Thank you.
But this is also, but I also think that this relates to the importance of educations like liberal arts education, right? So regardless of what field a student goes through, I think a student should be able to go through a curriculum and come out with a course that is going to prepare them to deal with a diverse workforce, whether that's through theoretical work, whether that's through empirics or whatever. I think that that's the work that we have to do as a university and as colleges. Otherwise, we're failing students.
Sure. I'd like to think that we DePauw graduates are educated enough to figure out what the problem is, and then astute enough to go out and try to fix it.
Yeah, that's true. But I think that on the one hand, we want to prepare students for that. I think students can graduate from DePauw without taking courses on race and being racially sensitive. And until we fix that issue, I don't think we can pretty much say that we're producing mass groups of people who are racially conscious. That's my personal opinion on that one.
Thank you. I'll be quiet and go to the chat room. You got a good question there.
You're okay, Max. There's a question in the chat, Dr. Riley. What sort of impact does the historical medical trauma, such as Tuskegee, Henrietta Lacks, have on the current COVID-19 situation? How does it potentially contribute to misinformation?
Absolutely. I think the Tuskegee experiment has certainly influences, particularly minorities, attitudes about healthcare and about different vaccines. And when we saw early people were reluctant to get vaccines, it was primarily because of the historical hysteria surrounding the way minorities have historically been treated with respect to the doctor. My grandmother, to this day, talks about the doctors giving Black folk what's called, quote unquote, the black bottle, during the 1940s and 50s in the Mississippi Delta, which shapes fear around getting things like a vaccine that comes out for a new virus or a new pandemic. We're also in an area where there is inherent misinformation around the virus and what's out. We also disagree on facts And this also contributes to our inability to really confront things as best we can. Think about this. We are in the middle of a global pandemic, and we have people who are so upset to say that we have people who are suing government because of mandates about wearing a mask. Now, let's back up to the Patriot Act, which was an inherent violation of people's individual privacy. And so, but this is not new in this nation. There's also always been frictions between individual liberty and public safety. And I think that, this is just where we are with respect to this pandemic.
Thank you, Dr. Riley. Amanda also is talking about the work that her organization is doing in St. Louis, and about another organization doing some work on intentionally weaving in equity into the training programs for health professionals. Amanda, do you want to share further verbally?
Sure, I was just following kind of the comments Max was making and some of the questions around efforts out there to really try to, I guess, kind of move up the what's the word I'm looking for? Upstream, sort of trying to move upstream to really do some systems type change. And so the one was truly a shameless plug of a program with my organization where we're working really closely with medical students at WashU and SLU. But Flexner is another really kind of nationwide group that's trying to weave social mission into medical education. But I think the other thing is recruiting more BIPOC folks into the medical field. I mean, there's been a huge disparity in the number of Black physicians we see, and outcomes are showing that if patients feel better trust and feel better care when they have a provider that looks like them. So I think that's like another component of the conversation.
Oh, absolutely. Absolutely. And I think that's consistent too with a lot of the literature I've seen, that if there's congruence with the representation, is more likely to trust the medical professional, and also, just have a better relationship as well. So I absolutely agree with that.
I have kind of a statement and a comment, or kind of like a comment / question, Dr. Riley. So in having conversations with just friends or just people in my network about how many people you know that have passed away from COVID. And it's very interesting that when the conversations are happening, either via social media or in person, that the Black people have very high numbers, or a lot higher than their white counterparts. I've actually lost track. I don't know how many people I've lost to COVID, whether it be in my family, close family, friends. I've literally lost count. And so some of the conversation is that it's access, it's resources, it's location geographically, but I've also heard that it's due to lack of education about the vaccine. So I don't know if this is actually, well, I guess the question would be, would you define lack of education as like classified under access, or like where would you classify that, like politically? Like is it due to access? Is it due to the resources? Is it due to just being uninformed? Like how would we classify being uneducated in this arena? Does that make sense?
Yeah, I think part of it is just, especially with respect to Black people, is just this hysteria around not wanting to be an experiment. And when that happens, so there's a book called Medical Apartheid, where they talk about even during the colonial period, slavery era, how medical doctors would experiment on enslaved Africans in these barns. And so I think a lot of people have just been reluctant to say, okay, this is a new virus. We don't know much about it, but yet now we have a vaccine. A lot of it is also not understanding how the development of these things work. I know I've lost count on the number of people who have passed away from COVID. And even when we think about like now, I had COVID 3 weeks ago, and trying to get in to get a test was still not an easy task to do. Testing has been backed up. I think that in addition to the pandemic highlighting racial disparities, it has also highlighted some major systemic issues with respect to how our healthcare system is structured in the US. Having to wait 3 or 4 days out to get a test. By the time you get a test, your COVID symptoms may have subsided. Having to, at one point, I think we've gotten the vaccine access all together, but at one point it was difficult to even go in and schedule an appointment to get a vaccine at one point. And so these are real issues that people on the ground have to deal with. And imagine you're living in like the rural Mississippi Delta, you're living in rural Indiana, and you're trying to, navigate these parts, but also this healthcare discussion is so large. It's so many moving parts systemically. It's access, it's education, it's whether or not your state has the professionals to deal with it. It's dealing with the professionals, medical professionals that you encounter. So it's so many different moving parts with it. And I think part of it is we have got to deal with addressing systematic inequality in this nation. And when we say we want to address systematic inequality, we can't just talk about police brutality. We've got to talk about the way in which poverty, unemployment, all these different factors that are multi-layered are also having implications for our healthcare system and healthcare outcomes. Because if I go to the doctor when I was in Mississippi with my grandmother to ask questions, because a lot of times people walk away confused at what the doctor is even talking about, and these are just things I think that we've got to deal with if we want an equitable healthcare system. And some of it isn't intentional, some of it may be intentional, but I think part of it is just the way we structured these ideas, the way we've structured and even talk about healthcare. And it's not just the US. I think there are some other systems that are far worse globally.
Max, I see you've unmuted yourself, and then we also have a question in the chat. So Max, you want to go first?
No, I don't have a question. I'll mute.
You don't have a question? Okay. So there's a question.
Amanda just put another good one on.
Yeah. So have you heard or read much about the racial disparities in hospital ventilator protocol for COVID patients? I was aware of this at the very beginning of the pandemic, but haven't followed it since then, and curious if it's been addressed.
Yeah, so I don't have data on that.
I think we just lost Dr. Riley. He should be back. Remember, he is at a gas station. And we appreciate him for.
While he's gone, any of you know
I'm back.
about...
I'm back.
Okay.
Hello?
Yeah.
We can hear you. We just can't see you, but that's okay. Go ahead.
Okay, let's see what's going on here. Okay, so about the ventilators, I haven't really followed that, but I don't think it would be far-fetched to say that if we know Black people are disproportionately suffer from pre-existing conditions and other minorities as well, and they also have increased hospitalizations, that there's likely to be disparities in all.
Must be snowing.
Yeah, go ahead, Max.
Leslie, do you happen to know what the title of his new book is and what it's about?
Let me see if I can find it really quickly. I know he actually wrote it in conjunction with Dr. Clarissa Peterson.
Sounds like it's not quite yet published.
Not that I'm aware of.
I'm here.
Okay.
We can hear you. Can you tell us the name of your book, Dr. Riley?
Oh, the title of the book is Racial Attitudes in America Today, One Nation Still Divided. You can get.
I'm going to put the link in the chat for the book. And it looks like it is available. It has been published. And so I will put the link here in the chat. Dr. Riley mentioned that his internet is going out, and that is okay. He's given us a wealth of information this evening. Anybody else have any last minute comments or questions? We can certainly get those questions addressed by Dr. Riley and send those out via email if you'd like.
No, just thank Dr. Riley for his noble efforts. I know sitting in the gas station doing this is less than fun.
Yeah, yeah. We truly, truly appreciate Dr. Riley for being with us this evening. I do have a couple of parting messages for you. You will receive a post-event survey tomorrow morning. We would appreciate as many of you to complete the survey so we know what you enjoy and maybe some additional topics that you would like to see in the future. And last but not least, I invite you to continue to stay involved. We're grateful for your attendance tonight in our last Alumni College series for the month of February. We invite you to give up your time, talent, and treasure. This is your time to spend some time with us, whether it be attending events, whether it be through volunteering, mentoring a student, talking to a student, and of course, giving up your treasure. Events like this, sometimes they do cost, and we also have opportunities for scholarships for our students. So we do appreciate you giving up your time, talent, and treasure. So visit our website, see how you can continue to be plugged in to our alma mater. A couple of upcoming events. There is a McDermott Speakers Series featuring Laura Chio, class of 98, on March the 1st. And on March the 10th, we will have an in-person Cincinnati event with the Catherine F. Hubbard Center for Student Engagement. Again, we do thank Dr. Emmitt Riley for his efforts and his knowledge and wisdom this evening. And I'm just so appreciative that he made a way to be here this evening. So Dr. Emmitt Riley, we appreciate you. And then everyone else, thank you so much for tuning in. And thank you so much for your grace and your patience with our technology this evening.
Leslie, just one more question.
Yeah.
I'm looking at the video of Ed Schussler, and I think Ed may have been a classmate of mine or nearby. Can we get Ed to tell us what year he graduated?
Absolutely, absolutely.
Sure. My wife, Sharon, who's right next to me here, and I both graduated in 1965.
That's what I thought. I remember.
And I was a political science major.
Okay.
And I'm a retired attorney also.
Okay. Well, we probably sat in some classes together.
We probably did.
Probably recognize you. Nice to see you again.
That's amazing. See, that's why I love these. Oh my gosh.
And since I got the microphone shortly for a short period of time here, Leslie, I would say thank you. This was a very interesting, thought-provocative program.
Thank you. Thank you very much for that. We do appreciate it. And we'd love to just bring the college classroom to our alumni. I realize that things change over time, and our professors, they do a lot of research to bring their knowledge forth to us. So,
well, thanks for putting this together. This is a good one.
Absolutely. Our pleasure. Our pleasure. And again, thank you so much. Please reach out, Leslie Smith at DePauw.edu if you just like to chat or have any questions or comments.
Okay. Thanks a
lot. Have a wonderful evening.
Good evening.
Bye-bye.